Hello, I'm Nancy Hardy, and I work in the University of Maryland's Transplant and Cell Therapy program. So thank you for inviting me today. The slides we will adapt as we go through a little bit because some of it's been covered really well already. So just some disclosures about groups that I've worked with, some for money, some for generosity. So I'm not going to belabor this. We've talked a lot about it. This was the state of the art up until, the past few years, where someone with a diagnosis of severe aplastic anemia would be triaged into young, have a matched donor, transplant. Otherwise, we're going to go to immune suppression. So why there's a lot of non-malignant disorders that we treat with transplant. In some ways, aplastic anemia is more challenging because of the immune component to it. And so I thought I would focus on this as sort of a paradigm for talking about transplant in these diseases. So in the interim, and at the end, I'll come back to these same points that have been made by Dr. Patel as well. But really, transplant outcomes have improved a lot historically, certainly since the 1970s when we started doing it more frequently. But even over the past decade, really, our transplant outcomes have improved. And now we know that even though we can get people into a remission with immunosuppressive therapy with L-Trombopag, that there is, in a subset, going to be clonal evolution, including to some high-risk features that we don't want patients to get, and the risk of relapse. And if you take people to transplant, after those things are happened, the outcomes aren't going to be nearly as good as upfront transplant. So with that, I'm going to kind of review some of the things. This I'm not going to spend much time on because we already heard it, but basically, outcomes are improved if we add L-Trombopag, maybe with romoplastin or others as well. We get into remission faster. So that's part of the, sort of thought process in using immune suppression rather than transplant if there is increased risk with doing a transplant. So this we've already seen, but, the relapse rate is 40%. And meanwhile, getting into a remission and relapsing and getting to transplant, people are getting transfusions, they're getting alloimmunized, they're getting harder and harder to transplant. Maybe they're having infections. So here, I just wanted to kind of look at, this is survival after allogeneic transplant for severe aplastic anemia in young people and in old people, 19 and above. This is the way that they divided this up. I didn't take offense. And looking by different donor types. So we can see why, the recommendation was if you've got a match-related donor, go for it. These outcomes are good. If you get to the point where you have your best option is a mismatched unrelated donor option, then it was a problem. But it's a problem that's being addressed. By the time you hit 19, these numbers actually start to decline, but all except for the mismatched unrelated donor options were still getting good survival out to 5 years in 80% of folks. So this breaks up these same two things by the year of transplant. So at 2000, which we'd already gotten really good at transplant by 2000 compared to where we started, those lines are in the light blue. This is, dark blue. So dark blue for the young folks. And then as we've gotten better, even in young people where the outcomes have been good, you can see that we've really improved significantly. When you get older than 18, the numbers still go down, although you can see that in the recent era that things have continued to improve as well. So here, just for historical sake, I took these numbers back to 1975, where you can see from an EBMTR, European Bone Marrow Transplant Registry study, looking at first-line match-related donor allo. This is from 2000 to 2009. And this looks at age as an identifier of who does well and who doesn't. And here they broke it up by era, where the first line was now immune suppression. So second line transplant, what did transplant outcomes look like after that? And yes, there's been steady improvement. After 2000, the numbers look better here compared certainly to where we were in the 70s, but not as good as when we use first line transplant. I'm not going to go through this in detail, but every time someone does a review like this, the survival numbers get better. And so this is broken out. This is a 2022 chart. They're done periodically. How are we doing with transplant? And we're doing better. We're doing better over time, whether we use matched related donors or matched related donors. So either way, transplant outcomes are improving. And so then we have to figure out how to do the math. When is upfront transplant for older people or with not a matched related donor actually exceeding those that we've been doing with younger patients? So challenges in dealing with non-malignant disease is one, a lot of folks are allo immunized. They've gotten red blood cells from other people, allo, and they now recognize those as foreign. And so they come to us with an educated immune system of, I know what to do when something foreign comes into my body. So there's an increased risk for graft failure, that they're going to reject that transplant. Second is that allotransplant, when I treat leukemia, I want graft to work against the leukemia. And it's a fine line between graft versus leukemia and graft versus the rest of my body. So I got to walk that line. And if I walk it too closely and say, okay, we're not going to have any graft versus host disease, the leukemia has a much higher chance of relapsing. But that's not true with aplastic anemia. Aplastic anemia, in that particular diagnosis, I have to dampen the immune system to prevent rejection, but graft versus host disease or graft versus severe aplastic anemia, as far as we know, has no benefit to the patient. So we really have to figure out, how do we prevent them from rejecting this transplant, and how do we prevent them from walking away wishing they'd never had a transplant because they have a lot of inflammation in other parts of the body. The third thing to think about with non-malignant disease is you can make people better without being perfect. So when I have a patient with leukemia, I want to get everything up to the donor, because if the donor's tolerating anything about the patient, I'm afraid it's going to tolerate the leukemia and let it come back. Well, it turns out with severe aplastic anemia, with sickle cell disease, with a lot of non-malignant hematologic disorders, I don't need to be 100%. I just need to be good enough to make blood and stable there. So I'm not going to lose the graft, but the graft doesn't have to win and take over the entire body. It just has to be good enough to make blood. And then the fourth challenge in dealing with these is that when people have been transfused, when there's an immune-mediated component to the disease, the interaction between the patient's immune system being educated and watching carefully for anything foreign, and the donor's immune system, which is saying, where on earth have I arrived? I've got to clean up this mess. And the easiest mess to clean up is the bone marrow. There's an interaction that actually educates the donor cells to target the bone marrow elements even after it's all donor. So we have immune-mediated cytopenias that are a problem after transplant. So the goals to improve outcomes, to make it to the point where we have great outcomes with transplant and we don't need to take the risk of clonal evolution and advancement to leukemias or infections or alloimmunization, would be to limit graft failure, meaning the bone marrow is not working anymore and there's no more donor cells left. Limit graft versus host disease, which means the donor's immune system has decided that the patient's skin or gut or eyes or whatever is the enemy, and figure out a way to limit these immune-mediated cytopenias that occur more frequently in these disorders. Okay, current approaches. We use traditional agents that have been around for decades in combinations to try to limit the toxicities. And emerging approaches are to be smarter, to use, some of our immunomodulatory drugs to target very specific things so that we're not having many toxicities and potentially not having the immune-mediated secondary problems. Graft sources, we have plain bone marrow. We've got stem cells that are mobilized into the peripheral blood, or we've got stem cells that are in cord blood units that have been saved and stored. Bone marrow has the least graft versus host disease. Peripheral blood has the fastest engraftment. You've got somebody with neutropenia and a fungal infection, and you want that neutrophil count to come up, so peripheral blood's the fastest there. Cord blood, it's a baby's umbilical cord attachment to its mother. I mean, there just isn't much in there. And it works great for little people. By the time you get to bigger people, it's maybe not enough to overcome these barriers that we talked about with aplastic anemia. So now there's cord blood expansion. I can take that cord, I can put it with chemicals that I won't go into right now, and it'll grow into a product that looks a little bit more like peripheral blood. It's got a lot of potential. And this concept has been under development for years, and this year it's been approved by the Food and Drug Administration. So it is now a real viable option for transplant recipients with whatever diagnosis, if that's the best donor source for them. Graft versus host disease, we've relied on our calcineurin inhibitors, cyclosporin, tacrolimus. We add ATG in aplastic anemia. And the big, modern improvement is the utilization of post-transplant high-dose cyclophosphamide. So we're going to use chemotherapy to kill the activated lymphocytes that are trying to reject the transplant and those that are trying to cause graft versus host disease, and then, let it grow in a much more sort of hospitable situation. PT-Cy 15 years ago was kind of scary. What, we're going to give chemotherapy right after we gave this little tiny dose of cells, and but it works really nicely. It works in haploidentical, where again, you've got these huge barriers in terms of graft versus host disease, and graft rejection. So not unlike some of these non-malignant hematologic disorders. But we've also brought it into matched related donor, matched unrelated donor. And for malignant diseases, sometimes it works a little too well and you end up without enough graft versus leukemia. But in this setting, it seems like a pretty good idea. So wider adoption of this approach and using other approaches as well, different targets of the immune system, using ruxolitinib, like we heard about, to try to improve outcomes after transplant. Depleting these different cell populations, the CD3 T cell population, as well as the CD19 B cell population. Both are involved in all of the different immunologic toxicities as well as benefits. Different TCR subsets, or using a conditioning regimen that's antibody-based that gets rid of all of the blood-making cells that express CD45 with either a targeted antibody with a little bit of radiation attached, or a chemotherapy moiety, but much, much less toxic than a slug of busulfan or even a slug of cyclophosphamide. Okay, so this slide is really just a conceptual slide, okay? The more immunosuppressive a transplant conditioning regimen is, the better you're able to get in a graft against something that wants to reject it. And the more myelosuppressive or cytotoxic or deadly the chemotherapy regimens, the better they are at attacking things like leukemias. So the bigger the donor disparity, I've got a matched sibling, or I've got an unrelated donor, or I've got a mismatched sibling, or I've got a mismatched unrelated donor, the more immunosuppression you want. But these patients don't necessarily need a big slug to get rid of leukemia. They don't necessarily, and some of the bone marrow failure syndromes are incredibly fragile to those damaging effects of either radiation or cytotoxic drugs. You may cure that illness, but then you've damaged other parts of their body in ways that make them far more prone to developing secondary cancers. So again, I'm not going to go through all of this, but this really, kind of breaks down the different parts of transplant and says, here's, what's beneficial about it, what's limited about it. and gives some specific examples of those things that we just talked about. But for the sake of time, I won't go through this in detail. So then one of the hurdles that we have is transplanting older people. It used to be that older was more than 35 in transplant in general, not just for aplastic anemia. And then it got to 50, and then it got to 65. And now we really say the functional age of the patient is really what should decide if they need a transplant. For malignant disease, certainly, but increasingly, we're starting to wonder if that same logic shouldn't apply to non-malignant bone marrow failure syndromes as well. So this is a retrospective study of almost 500 patients with severe aplastic anemia that were older than age 50. And, 15% of them were actually over 60. And 90% of them had received standard therapy, which is, immunosuppression up front. And either they relapsed or it didn't work, and so then went on to transplant. Half of them survived, 56% overall survival, a little bit higher in matched related, and a little bit lower in unrelated. And so again, when you looked at the graph source here, it was not statistically significant. So it's not perfect, but these are people who now have no immune system and no hematopoiesis, and immunotherapy has failed them. So infections, bleeding, transfusions, it's not just about quality of life, it's about living life. They looked and they said, okay, what predicts which patients do well? And we thought of all the things that matter to us and that we're sure are going to make a difference. So the age of the patient, the age of the donor, the patient's gender, the donor's gender, whether we use TBI in the regimen or not, whether or not we use bone marrow or peripheral blood, all of these things are just, what we transplanters dream about. And it turned out that the only things that mattered were the patient's performance status coming in, whether it was greater than 90%, which means they can really do anything they want to. Maybe they get tired, but they could push through it, versus less than 90%, which some days I'm definitely less than 90%. That made a statistically significant difference in outcome, which ones got through transplant. And the other thing that still mattered was identical sibling versus a matched unrelated donor. But none of the other things that we were so certain were important mattered. I'm just looking at my time here. Okay, so terms of graft versus host disease. No one wants graft versus host disease in these folks because we don't need it. Again, looking at graft versus host disease by what regimen they got didn't seem to make a huge difference. It was statistically significant, but not quantitatively significant. But basically rates of graft versus host disease were higher than we wanted in these patients overall, regardless of whether they were over 65 or under 65. So this study, I just wanted to highlight, it's really, again, looking at the same, looking at older adults. Here I'm looking at high-risk MDS, completely different disease status, okay? But high-risk MDS in older adults has a notoriously horrible reputation. Like if we do transplant, it's not going to go well. And it's not going to go well if we don't do transplant, and what are we going to do? And so the question was, okay, should we be trying to transplant these folks? And so these were older patients. The mean age was 65. And they were biologically randomized. I have a donor, and I don't have a donor. And we just see, then this looked kind of prospectively at what happened. Patients were up to age 75. They all had reduced intensity conditioning, or they had best standard care, which could include a hypomethylating agent for MDS. And we see that the patients with a donor, did I lose it? Yeah, there we go. Did significantly better in terms of overall survival than the patients that were randomized to best supportive care, including a hypomethylating agent. And they did better whether they were younger than 65 or older than 65. And importantly, they did a follow-up study looking at quality of life in people that were alive after the two, and they were about the same. So this improvement in survival didn't come at the cost of a worse quality of life. So what that teaches us is that maybe we don't know if it's right or wrong to transplant somebody that's older if they have a disease with high mortality and morbidity associated with it, that just to maintain an open mind. So I wanted to sort of shift a little bit away from kind of those data and talk about the DEI component to this. So the CIBMTR, our National Registry for Transplant, does collect data by race and ethnicity. And so their abbreviations are pretty standard here, but this is by type in the past 3 years, right? So this is modern data. So we've got non-Hispanic whites, okay, matched related donor, matched unrelated donor, haploidentical donor. Some of them needed a mismatched unrelated donor, and a few needed cord blood. You move into Hispanics, populations, people who identify as Hispanic, and all of those numbers just get crunched. I mean, altogether, they're not much more than the number of whites who have a matched related donor. Far fewer are going to transplant, and it's really across the board in terms of what their donor source is. Same but worse for non-Hispanic people who identify as Black, and we're still for Asian, which is a broad Asian category. It's not East Asian necessarily, but it's a much broader category. So we see that there definitely are underserved populations in the transplant world because the incidence of diseases doesn't vary like this. These people are not getting transplants because they're not getting sick. They don't have donors, which is what this is looking at, but there are a whole host of other things that some of these communities may lack as well. And so then we look at the specific diseases. Again, they're broken out in the same categories. And this is now the percentage of the transplants performed. So that, you know, for different populations, that the height of how many is much lower. But you can see here for malignant disorders, the percentage of transplants for malignant disorders is higher for white people. And then the number for Hispanics, really high in ALL, which is weird and interesting. But higher, significant, you know, it's higher than, certainly it looked on the others for aplastic anemia and other non-malignant diseases. When you look at non-Hispanic Black populations, a much higher proportion of the population is treated for non-malignant aplastic anemia or other diseases compared to malignant diseases. This is about access. This isn't about the biology of incidence of these disorders. This is not a study in non-malignant disease. It excluded non-malignant disease to see as a proof of concept, why did it do that? Okay. Can we cross that barrier? Can we take an unrelated donor that doesn't match, and how deeply can they not match to go? Because a lot of people don't have a good matched unrelated donor. And so they took it down to where people would be haploidentical. Only half of their tissue typing matched an unrelated donor. An unrelated donor. I mean, that's a huge, gap. That's something that made me gasp 10 years ago. I mean, just who would think, no, there's absolutely no way. And so we opened the study up. People don't have donors. And, there were a couple of things that were interesting about it. The first kind of phase 2 was published a couple years ago. The University of Maryland had an opportunity to participate, but it was open at several centers, many centers around the world. There's a follow-on study that's currently accruing, although it's accruing really fast, and it is probably going to close in the next few months. And basically, there's no comparator arm. We're just looking, can we do this? And we took a pretty conventional post-transplant cyclophosphamide approach. We used bone marrow in that first study. because again, it's a safer, less GVH causing, and that's one of, when you cross that many HLA barriers, GVH and rejection are your two hugest problems. And the data looked kind of like they do for haplo-related. I mean, and which looks about the same as for matched unrelated or for matched related. We did it. And not only that, the outcomes looked pretty equivalent to what we would see with our more conventional transplant types, which is astonishing. The other thing, which was not deliberate, was that I don't have the number in my head, but nearly half of the study participants were underrepresented in the bone marrow transplant registry. So they're the ones that were going to not be able to get a donor. So those numbers that I showed you on the graph before, where you've got whites and then you've got everybody else, this opens that playing field up for that particular barrier. We can find a donor now. And we're doing a follow-on study currently, the one that's so rapidly approving, using peripheral blood, which is a lot easier to get an unrelated donor to agree to. And it's important for non-malignant disease too, because peripheral blood does get that graft in faster. And if we can do it safely by combining post-transplant Psi with ATG, and if you gave me another hour and a half, I'd be able to talk why I think that's so fascinating. But it really does open it up. You know, this is now something we can try in non-malignant diseases. We never would have ever thought we should try it before. To lots of advances in the transplant field. University, this is a plug for us, and I'll just do it quickly, but this institution does great at recruiting minorities, and we're recruiting minorities for clinical trials, recruiting minorities for transplant, recruiting, being able to treat minority populations with transplant, with CAR T-cell therapy, whether it's auto versus allo. So somehow, and I would love to figure out how, we cross some of those barriers, because our numbers aren't this much for everyone but whites and this much for whites. A quarter of our allos are people who identify as Black or African American. 40% of our autos for myeloma identify as Black or African American. Our numbers look completely different than those other statistics. And I think it's because we're really terrific people, but that can't be all of it. It can't be all of it. Somehow we are doing it. And I have no idea. I saw these numbers and I'm like, whoa. And let me tell you all, the FDA now wants data on these underserved populations. And all the trials are coming to us now saying, we think you guys can help us. But I don't know. It'd be really interesting to do a deep dive. What are we doing? I mean, it's great, but how are we pulling this off? And importantly, in clinical trials, and here in Baltimore, that's a particular issue for Black and African Americans, is clinical trials and whether you can trust an institution to have your best interest at heart. 50% enrollment of our clinical trials across the cancer center and in minorities. So that's the infomercial. That's it. Okay. So we see that the paradigm now is shifting on who we bring for with severe aplastic anemia. I've got a minute and a half of my 30 minutes. So now we go up to 50 on an official published, black and white algorithm. So people are starting to buy the fact that we can transplant across age barriers and unrelated or related matched donors are fair game. Now, that's not to say, oh, this patient's 49, we're taking her to transplant. And meanwhile, her heart's weakened because she's been anemic for so long and she doesn't have a caregiver. I mean, you got to still look at the patient and the situation and say, how can I make transplant a safe and effective option for this individual? And if you can't, you got to admit it. So this is looking at this haploidentical approach in severe aplastic anemia. They had 81% 1-year overall survival, which is amazing. And incidences of graft versus host disease, the dreaded nasty complication of haploidentical transplant, was acceptable. Relatively low, certainly no higher than in other populations. We'd love to get it lower, but we'll take it. And then currently, the BMT-CTN has got 2 trials going on, one for pediatric patients and one for adult patients who have either less than 25 or more, who don't have a matched related donor. They're going to get upfront BMT. With PEDS, it's HAPA-related, or I think both of them allow mismatched or matched unrelated donors. We're using low-intensity conditioning, and the prophylactic regimen varies between the two. In pediatrics, we don't have quite as many barriers, and so a more conventional GVHD prophylaxis is used, whereas for the adults, the post-transplant Psi is being used. So this is going to give us answers that we don't currently have. For the sake of time, I'm not going to go into these other novel ideas about how we can improve transplant outcomes, get faster engraftment without graft versus host disease. But they're there and they're cool. And so the current algorithm that we think about does look a lot like what Dr. Patel was saying. This patient, we think, has severe acquired aplastic anemia. Let's get a transplant consult, and then let's go from there. And ASH this year has as one of its clinical practice guideline work groups, severe aplastic anemia is one of their agenda items to try to make sense of the data I just tried to show you. What should we be doing now? So that's a priority for ASH, and that's a good thing for the community with non-malignant disorders.